All right. Welcome, everyone. My name is Jason Grebley. I'm a professor at the Kirby Institute. Welcome everybody to this session. I'd just like to begin by acknowledging the traditional custodians of the lands on which we're meeting, the Bidjigal people of the Eora Nation. We're really fortunate to be able to work and live and play on these lands. And so just pay my respects to any elders past, present, or emerging. And just extend that respect to anybody, any Aboriginal and Torres Strait Islander peoples joining us today here in the audience and online. Just some housekeeping to start off with. The format of the seminar is going to start off with a couple of, actually we've changed it. This is the script. We're going to start off with a video that opened the conference in Cape Town. And I don't know, I was very emotionally sort of moved in the sort of spirit of things, and it's just a really nice sort of display from the community. And then we're going to have some presentations from some people that presented, and then also sort of a rapporteur of the clinical workout. So so if you're joining us online, you can ask questions throughout by clicking on the Q&A icon at the bottom of the screen. And for the people in the room today, there's microphones on either side. All right, so away we go.
Distinguished delegates, ladies and gentlemen, welcome to the 13th International Conference for Health and Hepatitis C here in Cape Town and in Africa. My name is Ahmed Said, the Regional Coordinator for the African Network of People Who Use Drugs. And I am really excited to show you the great work done by the community-led organization in African region. Here you go. The networks of people who use drugs are on the front line of the public health response to HIV and viral hepatitis. We are giving out sterile needles and syringes and other harm reduction materials. With the help of Unitide-funded hepatitis C portfolio, drug user-led networks, Egypt, Nigeria, South Africa, and Tanzania are studying the use of low dead space needles and syringes. Our networks are also at the heart of the response to opioid overdose, distributing naloxone, educating our peers, and stepping in to save community lives. Our activists are also working to reach people with opioid dependence to highlight the benefits of opioid agonist maintenance treatment like methadone and buprenorphine. Once again, with the help of the Unitide study, Egypt, Nigeria, and Tanzania are studying the use of long-acting depot buprenorphine in low and middle income countries. Our groups are also reaching out to our peers with dried blood spot testing and helping them access HIV and HCV treatment and support with other medical conditions. Our peers also deliver wound care treatments on an outreach basis, helping to address injuries linked to injecting drug use or living outdoors or in exposed settings. Our networks and their leaders are organizing with other key populations. We are organizing together within the African region and supporting a new generation of drug use-led networks in Africa, including Zambia, Egypt, and Ethiopia. Our drug user groups are planning together, helping develop the quality of drug services and advocating with the policymakers and state authorities. Across the region, our advocates are trusted voices speaking about our communities' living experiences from the local through to the global. You are joining the region where the networks of people who use drugs are flourishing and making credible impact on the ground. Welcome and have an opportunity to learn more about the amazing work done by the people who use drugs in Africa. Welcome to 2025 here in Cape Town.
Cool. So that's how the conference began. So yeah, Ahmed is amazing. He's part of the African network of people who use drugs. And yeah, that was, so if you wanted, I think that gives you guys a good insight. I don't know if anybody saw the big blue vat. That's methadone. So that was a project, I think, in Tanzania where they were distributing methadone to hundreds of people right out of a bucket. So anyway, so lots of amazing harm reduction work going on in Africa. So our first speaker, now we'll get into some research. What's that? Is it you? I have Anna Conway, but yeah. So Anna's a Dr. Anna Conway, is a research associate in the viral hepatitis clinical research program, and her research draws on epidemiology and social sciences to explore barriers to health and well-being for people who use drugs. And I think Anna is going to be presenting data from the SHARP study. So this is looking at hepatitis C reinfection among people in prisons. So thanks so much, Anna. And yeah, so all of these are a series of either full orals or short orals. I think all full orals maybe. Yeah. Okay. Go ahead.
Thank you. I want to acknowledge that this work was done on the land of the Vegetable people of the Eora Nation and pay my respects to elders past and present. So yeah, this is the SHARP-P study. I'll just give you a bit of background on hepatitis C in prison. So people in prison are less likely to complete treatment for hep C. Due to a multitude of reasons, but often people are in prison for short sentences and therefore they're less likely to achieve sustained virologic response. Opioid agonist treatment like methadone or buprenorphine is available in prisons, but access is really patchy across Australia and there's no needle syringe programs. So the classification of treatment outcomes in prison can be, and retreatment decision-making can be really challenging among people in prison, and we'll look a bit into that about what's happening in terms of how people are being retreated. So this was an observational cohort study of 16 prisons across the state between 2019 and 21. So to be enrolled in SHARP-P, people had to have current hep C infection, be reporting injecting drug use within the previous 6 months, and be scheduled to commence hepatitis C treatment. And this is the procedure. So people completed a baseline questionnaire, the hepatitis C RNA point of care test at baseline, and gave a plasma sample. And then people initiated onto treatment, and then the follow-up questionnaire and the test was completed at the end of treatment and every 3 to 6 months. If that point of care test result was detectable or an error, then they also gave a plasma sample, and that allowed for sequencing to detect if the recurrent viremia was reinfection or not. And then at those follow-up visits, if the point of care test was detectable, then the person went back onto treatment and they continued being followed for the study. At baseline, there were 150 people recruited. The majority were male, and only 16% of those were currently receiving opioid agonist treatment. 62% of those had injected in the past month in prison, and the majority were injecting buprenorphine or using needle or syringes after someone else. So for these, for the outcomes, we categorized all the cases of post-treatment viremia into 4 categories. The first was definite reinfection demonstrated by sequencing with a hep C strain different from the pre-treatment hep C strain or undetectable hepatitis C RNA result after 10 weeks and subsequent detectable. The possible reinfection was any undetectable RNA result post-treatment followed by a detectable result. The virological failure was demonstrated by sequencing, and the undefined post-treatment viremia was no evidence of cure or no sample available for sequencing with a detectable RNA post-treatment. There was 27 events of detectable RNA during follow-up among 21 people, and they were categorized into the majority were definite reinfection, 61%, 12% possible reinfection, 4% virological failure, and 23% undefined post-treatment viremia. We also know that in this study, among the 15 retreatments, a third used a salvage regimen without confirmed virological failure. And in this study, 3/4 of the events of recurrent viremia were definite or probable reinfection. We also looked at incidence of definite reinfection, and among 103 person years of follow-up, overall, definite reinfection was 15.5 per 100 person years. And here the confidence intervals are really wide, but there was higher reinfection among people with no opioid agonist treatment during follow-up at 24.1, compared to 4.7 among people with any opioid agonist treatment during follow-up. And then when we limited it down to only the people who had injected drugs in the last month of follow-up, there were 67 person years of follow-up. This was higher overall, 19.4 cases of reinfection per 100 person years, and much higher in people with any injecting in the last month at 45.4, compared to no sharing in the last month at 2.8 per 100 person years. So in conclusion, there was a high reinfection incidence found overall. There's evidence to treat recurrent viremia as reinfection in the absence of other data, because in prisons often there's the sequencing won't be done as standard of care, and there's often limited clinical data available. And it evidences that upstream interventions are needed to reduce reinfection in prison, such as removing short sentences, removing people from prison, providing needle syringe programs in prison so people don't have to share needles when they inject, and improving access to opioid agonist treatment. Thank you.
Great. Awesome. So I think we'll just go through and then we'll get questions at the end. Thanks so much, Anna. That's great. All right. So the next speaker is Annabelle Stevens, and Annabelle's PhD candidate, also in the viral hepatitis clinical research program, and also as a manager of hepatitis programs and policy units at New South Wales Health.
All right. Thank you so much. Today I'm presenting some of the data from the Australian Hepatitis C point of care testing program. And I too want to acknowledge the traditional owners of the land on which we're meeting today and pay my respects to elders past, present and emerging. So Australia has made some really fantastic and substantial progress in reducing hepatitis C prevalence, particularly among people who attend needle and syringe programs. You can see on the graph on the right here that we've reduced the RNA prevalence of people attending NSPs from around 50% in 2015 down to 10% in 2023, as seen in the Australian NSP survey. But we still have almost 70,000 people estimated to be living with hepatitis C, and traditional services such as primary care and tertiary clinics may miss people at risk of infection due to the structural and patient barriers to care. So it's really critical that we identify, the real world data and understand prevalence among different populations if we're going to achieve elimination by 2030. So the aims of this study was to look at people receiving point of care testing in the Australian hepatitis C point of care testing program between 2022 and 2024. We evaluated the prevalence of Hep C antibody and current Hep C infection and analysed factors associated with those. And we split up that analysis by different community settings and different subpopulation groups. So the national program is an observational study, and it aims to evaluate the scale up of point of care hepatitis C testing for point of care Hep C testing. We recruit participants from all states and territories across Australia, as you can see on the map there. And as of the 31st of July, 2025, we had 114 participating sites and over 47,000 tests completed. Inclusion criteria in the national program is being 18 years of age or older, and either at risk of hepatitis C or attending a service that provides care for people at risk of hepatitis C. Testing in the program is now based on self-reported status. So those who have never been told that they have hepatitis C before receive a point of care antibody test with either the INSTI or the BioLine. And if found to be positive, they then receive reflex RNA testing with the gene expert. Those who have never been told they have Hep C before receive immediate those who have been told they have Hep C before, we assume to be antibody positive, and they receive immediate point of care RNA testing with a gene expert. Those found to have current infection are also offered point of care HIV testing with the ELIA and point of care Hep B surface antigen testing with the ELIA. So just quickly, our statistical analysis included people or participants enrolled in community settings in 2022 to 2024. And as not every single person had an antibody test, we estimated antibody prevalence based on either an antibody test result, the RNA test result or self-reported history of infection. And then we conducted logistic regression analysis to look at patient factors and setting types associated both with current infection and hepatitis C antibody prevalence with the factors there. Just quickly as well, so our baseline demographics, you can see all of the states and territories where participants have come from. And on the right is our study population. So 38% were female. The median age was 44 years. Just under half had history of incarceration. 23% were on OAT at the time of enrollment, and 31% reported injecting drugs in the last 30 days. So I've skipped ahead to this analysis that we did, where we looked at the prevalence of current infection, so an RNA positivity, among people with a history of exposure. So out of all of the antibody positive participants who had current infection. And this helped us sort of understand who still remains to be treated and what's the engagement in care among our real at-risk population group. We did an adjusted odds ratio, as you can see on the right there. And what we saw is that people currently experiencing homelessness were more likely to have current hepatitis C infection. And those on OAT actually had less likelihood of current infection. And this was interesting because OAT is often more likely associated with hep C infection, but particularly in this group, it might suggest that people on OAT have greater access to care or engaging in care and may have been treated through sort of those existing care pathways. We also looked at this by setting type, and quite nicely, there was a lot of similarity by the setting types that we looked at here. It may suggest some equity across site types, but we did see a lower prevalence among drug treatment clinics at 17% and mental health services at 7%. And then quickly looking at treatment uptake, again, we are seeing quite similar results here by patient demographics. The one that stands out, though, is that those currently experiencing homelessness were less likely to have completed treatment within 12 weeks of their point of care test. And then by setting type as well, a little more differences here. I guess a few to call out. Needle and syringe programs and community outreach had lower treatment uptake within 12 weeks, but probation and parole services had higher, and the other group as well had higher treatment uptake within 12 weeks. So overall, we did find differences in antibody and RNA prevalence, particularly looking at people with previous exposure to hep C. 25% had current infection. People experiencing homelessness had a higher proportion with current infection, and people receiving OAT had a lower proportion. And then looking at the settings, people in mental health and drug treatment clinics had a lower proportion with current infection. And then among those with current infection, 51% initiated treatment within 12 weeks. However, homelessness was associated with a lower proportion of initiating treatment. And then into the settings, we saw a higher uptake in probation and parole and lower in community outreach and needle and syringe programs. And I think just something to flag there as well is that for some of these settings, they don't have treatment on site. It was sometimes an in-reach model, which was great to be able to provide testing, but participants may have had to go elsewhere for treatment, which may have had an impact on the treatment initiation. So in conclusion, we really have made a great progress towards elimination, but we need to look at where the gaps remain. Potentially the structured environments like drug treatment clinics and probation and parole could support better treatment follow-up. And then need to think about sort of integrating testing into high prevalence sites like NSP and drug treatment, but then target testing appropriately into the more low prevalence sites to those only at risk of infection. And really think about how we can tailor the strategies based on the different barriers and enablers of those services to enhance our treatment initiation. Thank you to everyone in the national program. Thanks.
Awesome. Thanks so much, Annabelle. And I forgot to mention that Annabelle actually won the award for the top ranked abstract at the conference for this. So her PhD student. So yeah, amazing work. All right. So our next speaker is Grace Burton-McKeigh. So yeah, Grace has actually also just started her PhD, which is super exciting. And yeah, she's also in the viral hepatitis clinical research program and shifting gears a little bit, which is great. Some really neat work that she's been doing under the leadership of Alison Marshall.
Good afternoon, everybody. So today I'll be giving a quick summary of the presentation I gave at INHSU and following that up with some insights from several talks that I attended focused on gender inequities in drug use, HIV and hepatitis C care. Before I get started, I would also like to acknowledge the Bidjigal people of the Eora Nation and pay my respects to their elders past and present. All right, so at INHSU, I presented a talk, Australian Healthcare Provider Perspectives on Managing Hepatitis C Treatment During Pregnancy, Current Practices and Pathways Forward. The aim of this study was to qualitatively investigate current hepatitis C care pathways for pregnant people and healthcare provider acceptability of integrating hepatitis C treatment and pregnancy care in Australia. There's several reasons why this study is important. Firstly, rates of hepatitis C among women of childbearing age and pregnant women are increasing internationally. In Australia, women of childbearing age who inject drugs are 53% less likely to receive hepatitis C treatment than women aged 45 years and above. So in light of these inequities and growing evidence that suggests DAA treatment is safe and effective when delivered in pregnancy, the USA is permitting treatment for Hep C in pregnancy on a case-by-case basis, and we expect Australia to soon follow suit, especially as the evidence for Hep C in pregnancy, the treatment of it, grows. And so how we did this was we conducted in-depth semi-structured interviews with healthcare providers with experience caring for pregnant people with hepatitis C or at risk of acquiring hepatitis C. And so one of the main themes that came out of these interviews is that care pathways for pregnant clients at risk or with hepatitis C and their infants are incredibly fragmented. There's a lot of variability in terms of when testing is happening and also some uncertainty regarding infants. So just to briefly walk you through this pathway, if we start in the pink-purple box, pregnant clients, healthcare providers were confident that all pregnant people should receive a Hep C antibody test during their pregnancy. People who test positive for hepatitis C then were more often than not referred to an infectious disease physician. And sometimes this was based just only on an antibody test. And then moving to the yellow boxes for infants, that's when you start to see more clearly the variability in terms of who is managing infant follow-up and testing and when testing is taking place, especially in that RNA screening box at the bottom. And this is an interesting finding because there are some national level guidance that has some recommendations on when testing should take place and who should do it. And another significant theme was that when we asked healthcare providers what they thought about integrating antenatal treatment, there was quite a lot of discordant views regarding who should be responsible for managing this treatment. So for example, many providers thought that obstetricians should be responsible for providing hepatitis C care because they would obviously spend the most time with that pregnant person. However, providers acknowledged that this was probably more of an ideal situation, unlikely to happen in real life. Because hepatitis C treatment was seen as very beyond obstetricians' traditional scopes of practice, and because they already have an overwhelming workload. So as you can see in the quotes here, both physicians said that it would be the ideal model if it was integrated into maternity care. However, participant 12, an obstetrician, says maternity clinicians simply do not have the time to add an extra service to their workload. To be perfectly honest, there's probably things that would take priority if they had more resources. Okay, so to wrap that up, findings from this study illustrate the fragmented care pathways for perinatal hepatitis C care and highlight discordant views among healthcare providers regarding who should deliver treatment and what care models should look like. And the next steps for us is to compare these provider perspectives with those of people who have lived experience of hepatitis C care in pregnancy. So moving on now to my summary of some of the talks at INHSU. Starting with Karen Pinar. So her talk really set the tone for the gender-focused talks that followed, particularly on day 2. So she described how women who use drugs experience a multiple whammy of stigma, which prevent them from accessing health services. For example, women who inject drugs are often perceived as more deviant and more promiscuous and not living up to the normative ideals of femininity. She introduced the concept narco-feminism as both an advocacy tool and a framework for policy and research, a concept that insists women who use drugs have the right to pleasure, safety, voice, and autonomy within feminist movements. Hanifa Salem, her talk reminded us that biomedical interventions like PrEP won't work in isolation. Women who use drugs in Tanzania face overlapping challenges like stigma, poverty, and violence, shaping both their mental health and ability to engage with HIV prevention. Indeed, it was through the study that many of the women who participated heard about PrEP for the first time. Her research highlighted the need for the integration of mental health, psychosocial, and HIV services. So these talks collectively show that pregnancy is a critical but underused opportunity for hepatitis C elimination. Neliswa highlighted that most hepatitis C cases in South Africa are also among women of childbearing age, but antenatal antibody testing is rarely conducted despite it being recommended as routine. She is one of only 4 hepatologists in South Africa, and she is currently prescribing treatment in the antenatal period with great success. And she was very surprised that Australia wasn't doing it right now. So Catherine Chappell, she presented findings from the STORK study, which has been recruiting since July 2022. And so the numbers on the screen reflect recruitment up until September 2023. And she did, in her presentation, speak to a more updated results, recruiting more than 80 women at this point in time, but I just did not have those exact treatment numbers and didn't want to lie. So that's what we have here. And then lastly, Madeline McCrary, she showed how shared decision-making models seem to be improving treatment uptake. So since March 2024, their clinic has been offering antenatal treatment in a shared care decision-making model as per US guidelines. And in this context, this looks like pregnant people having an initial consult with an infectious disease physician at any time during their pregnancy. And so some numbers that she shared is that 11 out of 16 women who had one of these shared decision-making appointments initiated treatment during pregnancy. An important point, though, that she did raise is that among those participants who opted to wait for the postpartum period to initiate treatment, she said many were lost to follow-up. So that just highlights that postpartum period remains an important challenge regardless of if we have antenatal treatment or not. And so lastly, my key takeaways, they're nothing too novel, but firstly, is that there are some big gaps in the inclusion of women who use drugs in research. It was raised in discussions about some studies at the conference that women compose less than 10% of the sample. And so it's hard for studies even to detect any sex differences. And this did vary quite significantly across different contexts. And however, even when we have existing data, certain groups like pregnant women are often excluded, especially from clinical trials. And similar concerns have been raised among providers who we interviewed in Bump C. They said things like, we wouldn't even be having this interview if pregnant people were included in trials in the first place. My second key takeaway is that there is a need for gender-specific, not gender-neutral services for women who use drugs. Services designed for people who use drugs in general are rarely gender equitable. To improve access to PrEP, hepatitis C treatment, and opioid agonist treatment, services must be trauma-informed, trust-based, and integrate mental health, reproductive health, and assistance for gender-based violence. Sustained psychosocial care can also help keep people engaged beyond initial appointments and improve health outcomes for women. So thank you so much.
Amazing job, Grace. And I will say I had chatted with some people after the conference, and they felt that that was one of the best parts of the conference was the increased focus on gender this year. And just, yeah, it's great to see Grace and Allison's sort of leadership in this area. I think it's becoming a bigger and bigger space that needs more attention. So wonderful. All right. We're at the last go. So my pleasure to invite David Goodman-Meza up to present some of the work that he presented.
Hi, David Goodman-Meza. I think I know everybody here, but now welcome to the David Goodman-Meza Hour because I have 3 presentations to go through. This will be a little bit of a step to the side from hepatitis C and that ubiquitous Kirby PowerPoint template. So this is exploring potential underestimates in fatal overdose mortality across major metropolitan areas in Mexico between 2005 and 2019. So the whole study is described in the title. This was a very collaborative endeavor based on all the different logos that you see on screen, but it was especially led by Raul Bejarano, now PhD, who is looking for a postdoc. So if anybody has any money, please let me know. He's really good, and I can vouch for him. So acknowledgement of country, definitely want to acknowledge the elders past and present, but specific to this work, the Kumeyaay Nation of Northern Mexico, which is where I'm from and which a lot of this work by Raul was undertaken. And then I'd also like to acknowledge 2 harm reduction agencies that work in Tijuana and Mexicali, Prevencasa and Verder, who really provide these essential services and are really the only provision of services for people who use drugs in the area. This work was funded in part by the U.S. National Institutes on Drug Abuse for a training grant that Raul received, but I specifically want to protest the U.S. gutting of science that they are currently doing. And then lastly, no disclosures to note. And so we know in Mexico, I'm just going to go through kind of a story around the context of Mexico, because it's probably not is fresh in your minds, but we know in Mexico, people use drugs. Although we believe that that's not as common as people using drugs in their northern neighbors, such as the United States and Canada. And this is data coming from multiple surveys, national household surveys, similar to those done here in Australia and in the United States. And we can see an increase in the reported lifetime prevalence in substance use, with cannabis being the most common, followed by cocaine, amongst others. One notable thing that you don't see on this slide is really no opioids or heroin, because it actually is quite uncommon in Mexico, except in very certain pockets of the country, especially along the US-Mexico border, and especially through many years of research, especially by groups from, say, UCSD, they've really reported on the drug use and related harms in these regions, especially in Tijuana, Mexicali, and Ciudad Juarez. So while opioids may seem rare nationally, there are these kind of hotspots across the country. And we also know that fentanyl is used in Mexico, and work that I did in the city of Mexicali is during the COVID pandemic at an opioid prevention center with self-report from individuals stating that they were now accessing and using fentanyl. And then we actually took it a step further and we did drug checking at this site, which is also serves as a safe consumption site, where women would bring in their samples, and there were 50% of the samples were testing positive for fentanyl. And we also know that fentanyl is available in other sites across the country through wastewater analysis. So despite this knowledge, national drug policy has been actually quite inconsistent. And during several years of the last presidency of this Andrés Manuel López Obrador, also known by his initials AMLO. It took him really 5 years for him to acknowledge that fentanyl was being produced, trafficked, and used in Mexico. I'm going to go off script a bit because I'm not constrained to the 10 minutes that I was at INSU. But he would have these like Tuesday with the reporters on health. Every Tuesday he'd have a press conference and he'd talk about health. And at some of these, he would say stuff like, well, I viewed naloxone as just prolonging addicts' misery. So we shouldn't be doing this. See what's happening in the United States. All these people should just die. And so things like that on national TV. During that time as well, AMLO shut down the production, the methadone production at the only facility in Mexico, and buprenorphine is not available in the country. So all these people in treatment had really no option other than going back to the use of heroin and or fentanyl. He removed all funding from the harm reduction NGOs. And so if it wasn't for organizations like OSF, all of those NGOs would have probably had to shut down. Naloxone is actually prohibited for the use outside of hospitals. It's kind of somewhat as a controlled substance. And so the groups I've been involved with, we've had to like actually smuggle naloxone from donations from California through our trunks of our cars. And I already mentioned that last point. And so luckily now the country has started to officially report that fentanyl is present and has led to both treatment demand and overdose. But as you can see on the numbers, these are 180, 300, 400 in a country of 130 million people. So this brought us to an important question of what are the harms, right, of drug use in Mexico, specifically relating to overdoses, and what is the data, right? And so if we look at the official overdose statistics, we can see that, say, for the year 2019, in Mexico, there were only reported 235 official overdose deaths. For a country of 125 million, that would equate to a rate of less than 1 or 0.18 per 100,000, which is quite obviously ridiculously lower than these neighboring countries. And to us, it's just so ridiculous that we just do not believe in the data that is being reported in these official mediums. So just a reminder of how kind of this data comes about. When somebody dies, either in the hospital or an unwitnessed death out onto the street, either a physician, if it's like, say in a hospital, or somebody's being treated by a physician, will fill out a death certificate. If there's none, then the death has to proceed, or the deceased person has to proceed to a medical examiner, which in Mexico, it's denoted by the alias SEMEFO. And then they fill out this death certificate. These death certificates are coded with some kind of cause of death, which is then coded to an ICD code, which then enters national statistics, right? So there's a lot of different pressure points along that pathway where things can break down and then the data not get to where it needs to be. So we, now going into the research about in this project, is that, well, we had a hypothesis that overdose deaths in the country had been systematically coded using other codes than those that should be used for overdose deaths. And so we had two aims. One was to identify which codes were being used as proxy codes for overdoses. And then based on these codes to estimate a crude drug-related mortality rate, both at the national and at key metropolitan levels. So for aim 1, we submitted freedom of information requests to all 32 Mexican states, and requesting data from autopsies where toxicology was performed. And so we requested age, gender, the probable cause of death that they listed, and then what municipalities and what substances they found in that toxicology testing. And so the key here is we wanted to get data back saying, well, the dead body tested positive for fentanyl, but then they coded it as pneumonia, right? And to figure out which were these codes that they were using instead of coding it as an overdose. It's really cool that in Mexico, you can download the official mortality database. They have a line listing de-identified of every person who has died in the country per year. And it gives you all this sort of data, where they died, what the official code that they put in was. And so that's downloadable. And then we downloaded some population level data to calculate the different rates. So here, for the statistical analysis, when we got the data from the medical examiners, we categorized those deaths as related to a substance if they were positive for opioids, cocaine, methamphetamine, or benzodiazepines. We excluded all deaths that were related to trauma, hemorrhage, or infection, as those were quite obvious cause of deaths in our opinion. And then we compared those causes of deaths between those categorized as related to substances and those that were not. We did Fisher's exact test, and those causes of death that were statistically significant, we then used as our proxy codes. In AIM-2, we basically estimated the crude drug-related mortality rates. So both for the standard overdose codes that you see here, and then for the proxy-related codes that we identified in AIM-1. To give this a little bit more validity, we tried to do this similar analysis in other countries in the United States, and then in countries in Latin America that had a similar GDP, and that we were able to also download a kind of line listing of all these deaths. We restricted the analysis to between 2005 and 2019, because of course 2020 and after COVID comes around and that kind of complicated stuff. And then we really restricted this to people aged 20 to 39 years, because this is really where we would expect the highest drug related mortality. And then because above these years, well, some of these causes of deaths could be just because these people had that cause of death. So it'll make a little bit more sense here. So going into the results of the 32 states, we received data from these 7 states, with the majority of line listings of toxicology data coming from Baja California and Mexico City. When we compared those with toxicology positive versus those with toxicology negative, those that were statistically significant causes of deaths were acute pulmonary edema, acute myocardial infarction, and acute respiratory failure. So then these codes were used as the proxy codes to calculate our estimates. So this is the standard overdose death rate for the United States in this kind of pink lilac color. Pardon my color blindness. So you can see the United States has this massive drug overdose rate, and you can see that in all the Latin American countries and all the other different colors, it's near down zero. So none of them are reporting any official overdoses. When you do our proxy codes, you can see that there are some deaths, but most interestingly is the blue line for Mexico. It has this really nice parallel to that of the United States. And it makes a lot of sense, because we think that, or we know that fentanyl comes from China to the United States through Mexico. And in 2013 is where fentanyl really makes its appearance in the United States. And you can see this upward exponential trend in that rate. Whereas in Mexico, you see that increase at a similar year. And then you can also see that for the United States, they really, because we think that it's a country that codes their deaths much better than our Latin American countries, their proxy-derived codes are almost close to zero for their rates. This is just to show that using standard ICD codes between 2005 and 2019, there's really no change in the epidemiology, if you would follow that, except for one municipality in that red box, which is Chihuahua, which they seem to be doing a good job of coding their overdose. That's with the actual codes. In these two maps, you see the changes using our proxy codes. And you can see rates that would be much more expected, especially higher rates along that US-Mexico border. So cities such as Tijuana, Mexicali, Juárez, Reynosa, Nuevo Laredo, that have rates all higher than the national average. So that was quite interesting. I think it gave it a bit more validity. There's a lot of hand waviness, right? There's no way that we're going to estimate the true overdose rates based on this data, other than exhuming all these bodies, and it's not something that any of us are going to do, right? So that's kind of my first limitation. The other limitations, these proxy codes, I don't think they would be as reliable in older age groups. Again, I'd mentioned the limitation around COVID. And now that a few years have passed since COVID, it'd be interesting to redo the analysis in these last couple of years to see what's going on. And then the other piece is that we didn't get data from the entirety of the state, so we have to say that the generalizability might not be there. So in conclusion, to us, it is likely that an overdose epidemic in Mexico has been hidden due to miscoding of deaths, although it is uncertain by how much based on our analyses. Reasons are many: limited toxicology capacity in the country, incomplete reporting, stigma and legal concerns, a backlog of death investigations because they're dealing with a lot of homicides, and then lack of uniform national standards for this. I'll jump over this. The paper just got accepted into BMC Public Health, so if anybody's interested, let me know and I can shoot it over to you all. So that's study number 1. So continuing with the David Goodman Hour, this is incident, patient-directed discharge, readmission, and mortality among people hospitalized with injecting-related infections. This project was actually led by Jeff Masters and Brendan Jacka. Brendan is here, so please save all questions for him. I presented in lieu of him at the conference. So persons who inject drugs are at risk of bacterial and fungal infections related to the act of injection. And there's a whole spectrum to these infections, which include skin and soft tissue infections and much more invasive ones like those that infect heart structures, bones, and joints. Most of these may require some kind of hospitalization and extended antimicrobial treatment, which could be up 4 to 6 to even longer, 12 weeks of antibiotics, which for many, these could be intravenous antibiotics, which tie a person to a hospital setting. And there are many physical and social factors that complicate hospitalization that are both due to the person, but also due to structural issues within the hospitals that make it hard for people who inject drugs to receive adequate care. And so at a population level, really little is known what happens to people who inject drugs during and after an infectious diseases admission. So our objective was to use administrative link data to describe these population level trends and their outcomes, and then factors associated to these outcomes. The outcomes we looked at were the incidence of injecting-related infections, patient-directed discharges, readmission, and mortality. So this was a study that was done within the confines of the New South Wales Hepatitis C Data Linkage Project, which I'm sure many of you know much better than I do, but it involves all of the hepatitis C notifications in the state of New South Wales. And then this has been linked to other administrative data sets like cause of death, opioid agonist treatments, hospitalizations, incarcerations, amongst others. We included those cases that had an unplanned acute hospitalization, that had codes for recent injecting drug use, which I defer on, that had an infection within 12 months of injecting drugs, and then had survived to discharge for this index hospitalization. Quickly into the results, over 9,000 individuals were included in the study, which amounted to over 18,000 hospitalizations. And you can see really that in the total number of infections has increased in the latter decade. And you can see between the blue and the red lines below that it seems like this is mostly due to an increase in invasive infections in this last decade, where we can see that the trend in skin and soft tissue infections is relatively stable. I present now the different risk factors for these different outcomes. Just to note that only significant predictors are presented in the graphics, and only the direction of the association and not the degree of the magnitude. So for patient-directed discharges, people who were at higher risk if they were residing in metro areas, if they were using stimulants, other drugs compared to opioids, if they had recent incarceration, and if they had a skin and soft tissue infection compared to an invasive infection. Readmission was quite common in this population. This is all data at 1 year. So 61% of individuals had a readmission. Again, many of them were similar risk factors. The ones that are different here are the inclusion of now people who had a recent alcohol code, and then also patients who during that first admission had a patient-directed discharge, and those who during that first admission had a longer length of stay. And then related to mortality, mortality was high in this population at 15%. Weirdly, here, stimulant use became a protective factor. The other ones, an ICU stay during that initial admission, an invasive infection, now became risk factors for mortality that weren't seen for the other outcomes. So kind of the takeaway is that people, especially people who use stimulants and are in contact with the justice system, are at highest risk for patient-directed discharges and readmission, and probably would be the highest yield targets for intervention strategies. One key thing is that interventions are likely needed to be very early during the admissions, as it was about 3 days, the median time to a patient-directed discharge. I just throw up here some strategies that might improve outcomes. Some are already being used at many hospitals, although some are still in the research pipeline, which could include multidisciplinary care, opening outpatient parenteral antibiotics, antibiotic strategies like early or oral switches, the use of long-acting injectable antibiotics like oritavancin and dalbavancin, and then the holy grail, I think, for many of us is to have an effective treatment for stimulant use disorder. So yeah, so that's that one. Okay, so now I was tasked with the beautiful task of being a rapporteur. I got to wrap up the clinical science abstracts. There was, I think, 3 or 4 other people, public health, community. I'm not blanking on the other couple. In the interest of time, I'll probably go through this. Part of this was trying to embarrass Jason with a couple of jokes. I won't nail them here. And then the other part was just trying to show off all the cute things that I did in Cape Town, which is go see the flowers, drink a lot of wine, and then go see Table Mountain. And then drink my butt off at the INHSU dinner, and then look like that the day of the presentation. Okay, so I did this mosaic play of the 30 some odd abstracts that I got to review to kind of show the breadth of what was presented in this realm at INHSU. And I think kind of the thought is that a lot of INHSU is very hepatitis C heavy, but I think this really shows, at least in the clinical sciences track, that it's really spreading out into other fields. Although still 50% of the abstracts were in the hepatitis C field, we now saw much more in harm reduction, opiate use disorder, HIV, vaccination, bacterial infections, amongst others. I also plotted this map of where the presenter was coming from to present at INHSU. Canada led the pack with 10 abstracts, but then other Commonwealth or British descendant countries, including Australia, South Africa, the UK, and the United States, or 3 and 4 abstracts. We saw one from Nigeria, and then a couple from Southeast Asia. The big one to me that's missing, of course, is Latin America, where I'm from. And then next INSU is going to be in Prague. And so we didn't really see anything from Eastern Europe. So from these bins, I just present quickly a couple of the abstracts. So from the hepatitis C efficacy clinical trials, to me, this was probably the most likely to be kind of practice-changing, game-changing. This was Stork-C that Grace alluded to. And I did ask her for her slides, so I do have her results. And it was really remarkable. She's enrolled, 80 participants in this analysis. I will not butcher her results. I'll just read them off here. She has 62 completed to treatment. 54 have attended a post-treatment follow-up SVR12. Of those, 96% cure rate. Of the 2 that didn't achieve SVR12 were really women with significant barriers to adherence, many dose failures. And then the neonatal outcomes were really great. No perinatal hepatitis C transmission, no cholestasis of pregnancy. Gestational age at delivery was 38, which was what to be expected. Preterm birth was about 12%, which is very much in line with historical controls of women with hepatitis C who are delivering babies. This was a sub-analysis from the EASE trial, which had compared 8 versus 12 weeks of sofosbuvir. And their primary analysis, they found no difference between the 8-week and 12-week groups. And then in this sub-analysis in the bottom left-hand corner, they really found that none of these factors that they looked at were statistically associated with efficacy. So just treat everybody. This was the Brian Conway show, Jason's old mentor, which he told me like 4 times. I taught Jason everything he knows. Well, he presented from the same data set 2 posters around related to treatment of acute hepatitis C, one in people with prior infections, and then the other specifically related to current or recently using drugs versus not using drugs, and everybody seemed to do great. So treat hepatitis C. Hepatitis C test and treat. I'll be embarrassed to present Temple, so I'm going to skip this one over in interest of time. In harm reduction, this was a cool one presented from somebody from Scotland. She presented this PneumoWave device, which is this little sensor that somebody can put on their chest and detects their breathing patterns, so that in the case of an overdose, somebody can be alerted and somebody come and administer naloxone or give any life-saving measures. So this was very pilot work, one showing that it works up here, that it can detect differences between normal breathing patterns versus apneic periods. And then they tied this around some qualitative work with stakeholders and people who use drugs. And it seemed to be acceptable. And it seems like they figured out, or people suggested that between 20 to 30 seconds of an apneic event would be a good time to send EMS services to assist. This was a study, kind of an early phase study of exploring low dead space syringes in people who inject drugs in Johannesburg. And really kind of showing that it, again, acceptable and leading to those next steps in the project where they're going to start rolling this out. Related to opiate use disorder, some of these I included, of course, because they were from South Africa and I wanted some applauses. This was the effect of OST in South Africa. Before the program, only about 1% of people were accessing OST. At the end of the program, about 4% of people who inject drugs were accessing it. But I think more important, or the kind of wider benefits seen in the lower left, are that HIV testing increased, ART uptake increased, hepatitis testing increased, tuberculosis testing, mental health screening. So all these kind of side effects, good side effects happened. So these are a bit of summaries, just that really we have a lot of work in hepatitis C elimination and care models, a lot of integration of harm reduction in clinical care, a lot of real world implementation work, really great rigor in the studies, and this really great community and equity orientation. I think the challenges really, like Eastern Europe, Latin America, the MENA regions are really not represented. I think content-wise, a lot more work needs to be done on, well, what's in hepatitis C world, life after DAAs, stuff around reinfection, use of long-acting agents for both MOUD, PrEP, and antibiotics, little work in stimulant use, polysubstance use. In other places like Canada and the United States, smoking, snorting is the primary route of use. I think we need more of a focus there, bacterial complications, and AI. So yeah, great place to stop.
All right. We probably were overly ambitious to try to include all this stuff in, but thanks so much everybody for all the presentations. I think we'll stop there. But yeah, massive thanks to anybody who is online, and thanks to everybody for presenting, and have a great day.